Dear friends, I'm very happy to be back in Chile, and I remember, probably you will not believe me, but Chile is the country with Portugal I visit the most frequently. And the first time, it's nearly 30 years ago, when I performed with the surgeon here the first laparoscopic cholecystectomy. Then I was invited by my friend, Dr. Mazzoli, Dr. Fernandez here, for a congress on endometriosis more than 25 years ago. And then I came back very frequently here, and it's really a pleasure to be here with you again. As everybody knows, I'm a surgeon. And my take-home message will not be no surgery anymore. My take-home message will be we should balance and individualize the treatment according to the symptoms and the pathology. And first, my first lecture will be on uterine fibroids, which is, as everybody knows, the most common human tumor and a significant source of morbidity. And we know that uterine fibroids has an impact on quality of life. Of course, there are risk factors. The race and ethnicity. We know that in the Black population, the prevalence of fibroids is very, very, very high. Vitamin D deficiency. There are more and more arguments in favor of deficiency of vitamin D as risk factor of developing uterine fibroids, and age, of course. Concerning the symptoms, the most important symptoms for the quality of life is the heavy menstrual bleeding. Of course, abdominal distension, anemia, pressure symptom, dysmenorrhea, and infertility as other symptoms. But the most important for a woman is the presence of heavy menstrual bleeding, also called menorrhagia. And we have several options. Surgical therapy, of course, non-surgical intervention, uterine artery embolization, magnetic resonance focus ultrasound, and HIFU, and also medical therapy. And in fact, we have to choose the most convenient treatment for the women. But the message is also that there are too many hysterectomies in the world for fibroids. Imagine that in the United States, 600,000 hysterectomies are performed every year, and more than 50 of them are performed for uterine fibroid. And on the right side, you see the importance of uterine preserving options. There are more and more women who want to retain uterus. This is a study performed in Europe, and as you can see here, that even at the age of 40, 49, there are a lot of women wanting to preserve the uterus, even in the postmenopausal age. I remember when I was a young resident, finally, it's true that at the age of 45, if a woman had the fibroids and heavy menstrual bleeding, the solution was hysterectomy. And that was more or less well accepted by the woman. But life is changing now. There is an evolution. And more women, even in the postmenopausal age, want to preserve the uterus. So that there is a shift from surgical therapy, which still exists and should exist, to to the target therapy according to the symptoms, thus with the goal to the symptom management. There are unmet needs, and I will try to answer with you, are the oral GnRH antagonists able to offer to us the new medical options? What are the GnRH antagonists? All of you know the GnRH agonists. We have used that for fibroids, endometriosis for more than 30 years. But the oral antagonist, GnRH antagonist, is completely different. First, administered orally, don't induce the flare-up effect. And very importantly, they cause a reversible suppression of gonadotropin secretion. And it results in subsequent rapid reduction of estradiol. There is the GnRH antagonist block the receptors with a suppression of LH and FSH suppression and secretion of estrogen and progesterone is stopped. The reversibility, let me insist on the reversibility, because we have used in the past a GnRH agonist, and we know that by injection of 3 months of GnRH agonist, sometime we were obliged to wait 2 months, 3 months, 4 months before observing the recovery of the ovarian function. I will show you later on what happens. And the first slide I would like to discuss with you is what we call here the therapeutic range, between 20 and 50 picogram of estradiol. Between 20 and 50, the bone mineral loss is minimal, and we have an efficacy on the lesions, endometriosis, or fibroids. If you compare with the GnRH agonist, it induces a full suppression. The high dose of GnRH antagonists induce full suppression, the low dose of partial suppression, and when you add back to the oral antagonist, you return in the zone called the therapeutic range, where you are efficacious with a minimal bone loss. I will discuss with you the result of the two studies published in different journals, and Obstetric and Gynecology, New England Journal, and American Journal. This is a study on uterine fibroids called Liberty, with a patient who were randomized between placebo, relugolix combined therapy, CT means add-back therapy, 1 milligram of estradiol, and 0.5 milligram of neta, this norepinephrine. And this dose of add-back therapy are used with all the treatment with the GnRH antagonist. Patients were randomized between placebo, relugolix CT, and in that study, they start with the oral antagonist alone, followed by relugolix CT. Afterwards, in Liberty 3, all patients receive relugolix CT, and there is an extension study I will discuss later on. All patients we were included in the study with patients were uterine fibroid and AV menstrual bleeding. It means more than 80 milliliters per cycle. And the primary endpoint that you can see here on the right side is the proportion of responders. What is the meaning of responders, a good responders? The patient is considered as a responders as the menstrual bleeding is less than 80 milliliters, and at least a 50% reduction in menstrual blood loss. Considered on the left side of the part here, in the Both Liberty study, you see the placebo group, more or less 15–18%, and with in orange, the patient treated by relugolic CT, and you see that 71% of the women are good responders. Meaning, again, I stress that they had less than 80 milliliters of blood loss each cycle and a reduction of 50%. As I mentioned, the study was continued for 1 year. And that was very interesting to see that the good result observed at the week 24, this it means 6 months, were maintained after 1 year. This slide shows the rapidity of the efficacy. It is the placebo, and of course, when the patient were switched to the treatment, we observed a good response. But notice here that very soon, at 4 weeks already, there is a drop of the menstrual bleeding drop down. Thus, we have a very frequent question from the patient, "Doctor, when the drug will be efficacious?" We can say to the women that after 4 weeks already, the mean menstrual blood loss will drop down by over 50%. And at the end, you see that really the results are very well maintained, and there is a high responder rate in that treatment group. Imagine this, that all these women had heavy menstrual bleeding. Just analyzing the percentage of amenorrhea, it's important. Imagine just that more than 50% of women who had heavy menstrual bleeding are in amenorrhea. And after 1 year, there is an increase of the amenorrhea rate, and we are more than 70% of women who are in amenorrhea. Of course, analyzing the symptom severity and quality of life, you see that in all group of patients, when compared to the placebo, there is an improvement, and the symptoms are less severe. Importantly, what about the uterine volume? Probably because of the add-back also. There are not so many decrease of volume of the uterus, but there is more or less 20% after 6 months and 15% in the group of relugolic CT after 1 year. You can ask me, what is the group here? That is, in the study, some patients were treated with relugolics alone, and after 12 weeks, they were switched to relugolic CT. Thus, it's logical that with relugolics alone, there are more action on the uterine volume. But this drug is not available in Europe. The relugolics alone is not available in Europe and in South America. Only available in Japan, and I don't know why they refuse to deliver the relugolics alone to the other countries of the world. This, after 1 year, what happens? In fact, you see here the patient were treated, you have seen the result until here. And thus in the study we decide to stop the treatment because it's important to see how fast is the recurrence of the symptoms. And uterine fibroid is completely different than endometriosis in terms of recurrence, at least, of the symptoms. And thus the patients were randomized after treatment between placebo or relugolix of retreatment. And what you may observe, that the patient treated for a long time with relugolix CT, the good results were well maintained. Thus, the total treatment duration was 2 years. But I will try to explain that correctly. The patients were switched to placebo. You see, a very quick recurrence of the symptoms and the heavy menstrual bleeding. In fact, this treatment proved that in more or less 50% of the case, you will observe after several weeks recurrence of the heavy menstrual bleeding. And it's quite normal because you have blocked the estrogen secretion with the GnRH antagonist. You stop the GnRH antagonist, there is a rapid recovery of the ovarian function. But what is very important, that in the study by Allende in United States, they retreat the symptomatic patient. And they were able to prove that by retreating with relugolix CT, that were able to stop the bleeding. What is the take-home message of that? I guess that maybe the woman of the doctor would like to stop the treatment to see what happens. And we have to know that 50% will recur with heavy menstrual bleeding. But we can tell the patient, okay, we may stop the treatment if you want, or we may continue if you don't want to have a bleeding anymore. There is a 50% recurrence rate, but we can restart successfully with the treatment. But the majority of the women, at least in Belgium and in Europe, they would like to continue until the menopause. They don't like to experience again the bad experience of the heavy menstrual bleeding. The product works very well. Is it safe? What about the headache and the hot flushes? There is no huge difference between placebo group and the treated group. Even, of course, in the patient treated by GnRH antagonist alone, they experience during this period more hot flushes. The add-back allows the women to have less hot flush and less bone mineral density loss. An important question is the bone mineral density loss. And the patients were treated, you see, for 2 years, and there is no difference between placebo and relugolix CT concerning the evolution of the bone mineral density. Thanks to the add-back, we know from the different studies that if you administer GnRH antagonist alone, the bone mineral density loss will be more or less 3 to 4% after 6 months. So that the combination with estradiol and norethistérone is really mandatory to avoid the bone mineral density. Very frequent questions, because some women will receive the drug, and I can imagine, for example, I'll give you an example. A black lady, 18 years, with a multiple myoma. In the past, of course, we had performed surgery, myomectomy. But we know that if we do myomectomy in a young lady of 18 years, the recurrence rate after 5 years is more than 50%. So that there are several indications for the medical therapy to prevent the recurrence and to avoid surgery waiting the right time for surgery. So that some young women will take this type of drug, and the question is, what about contraception? And the answer is that no of the women ovulated during study treatment. There is no ovulation, and importantly, the mean time to recovery the ovulation is very quick after that stop. So that, in conclusion for this part, long-term regular combined therapy is a good option. It reduces symptoms and maintains long-term safety. Thus, be aware that I'm not telling you no surgery anymore, no alternative treatment. The take-home message is we should individualize the treatment. It's not one surgery, it's not one medical therapy, it's no one. You should adapt the treatment according to the age, the desire of pregnancy or not, the desire to maintain the uterus, and the age of the patient, of course. So that the conclusion is, of course, the study with relugolic CT has proved that we may reduce the menstrual blood loss with a great efficacy. We can improve pain in patients with moderate to severe at baseline, and there is a reduction in uterine volume. It's generally well tolerated, with an overall incidence of adverse events similar to placebo. Thank you for your attention.